Elma Heidemann è stata per una decina d'anni di...
For some 10 years, she was the director of accreditation in Canada. She coordinated the ISQua accreditation group, and she continues being a consultant for accreditation all over the world, among which also the Veneto region, and we are particularly happy to have her here.
And to play. How do we play? Where do we start?
Yes. It's difficult to move it. Okay, here it is.
There. Ah, grazie. So to Andrea and Franco and all the colleagues that are here, I want to say how pleased I am to be here, to be able to talk to you for a few minutes about what the title of my presentation says, and that's Lessons from Accreditation Canada, some international lessons, and some lessons from ISQua. So Rosa has started the lessons learned, so I'm going to continue that. You will notice that the Accreditation Canada is a name change for the Canadian Council, which has taken place in recent years. So we are no longer the Accreditation Council, we are now Accreditation Canada. I had the privilege of, as you heard, being with Accreditation Canada for 15 years. 11 of those were as CEO, so the lessons that I'm bringing to you from Accreditation Canada come from my experience there. So let's go. I would tell you that my lessons may seem very simple to you when you see them written down, but the implications of them have been quite dramatic, certainly in my life. So lesson one for me was that quality needs definition. It sounds very simple. We all grew up with Avidus Donabedian and his wonderful books, but in my world, people began to ask me, if you are an organization that assesses quality, how do you define quality and how do you demonstrate the quality? So, what is quality? We needed to define it in terms of measurable attributes, something we could measure through accreditation. What we came up with was very complicated in the beginning. Over a number of years, it got more simplified and probably more usable over the years. And I'm just going to show you what we came up with, a quality framework, and many of you may have seen this before. This framework consisted of a definition of quality in terms of 8 dimensions. So the first dimension was that quality had to have a population focus. It had to focus on accessibility, that is, providing timely and equitable services. It had to focus on safety. It had to focus on the workplace, because without a quality workplace, we could not have quality care. It had to focus on client-centered services, on the continuity of those services, on effectiveness and efficiencies. Now, what did that mean for us? Well, it meant that once we established these dimensions, we then had to implement them into our standards, our accreditation standards. So each standard and criterion in the standards was then labeled with one of these dimensions. Now, it doesn't mean that there weren't possibility of more than one dimension per standard, but we had to have a primary. a primary allocation. And we did this through a consensus process. We assigned a dimension to each standard and criterion. And of course, then we automated our standards so we could look at all of these dimensions. We could pull out various dimensions. If we wanted to look at effectiveness, we could pull out all the standards related to effectiveness. We could pull out all the standards related to patient safety. So we could begin to summarize accreditation performance by dimension. This was for us a major step in trying to define quality and trying to decide if healthcare organizations were actually delivering quality care. Now, there was refinement over time, but I must tell you that this system needed continuous refinement and is still being refined today. So we've still not arrived at an absolutely wonderful definition of quality and how it can be described in measurable terms. The second lesson for me was that safety is the key starting point for quality. Safety is not something different from quality, but that it had to be a starting point for quality. So, like all of you already know, the quality improvement began to focus on safety. There were major studies coming out of most countries. The big ones, of course, were in the US that started things going to err is human and crossing the quality chasm. We had our iteration of this study, which produced similar results. It was done by two researchers called Baker and Norton, and ours was called the Canadian Adverse Events Study in 2004. We had similar results, as I said. We then came along and joined in the international collaboration, the WHO World Alliance for Patient Safety in 2005. We had our own national collaboration. The Canadian Institute for Patient Safety was born, and certainly Accreditation Canada was part of creating that institute. So what did Accreditation Canada do as a result of this whole movement in safety? Well, the first thing was that the content of the standards related to safety was increased. We created something which we called the Required Organizational Practices, or ROPs. And these were target areas with safety implications. And these areas were assessed during the accreditation survey. As of today, there are a number now of entrenched ROPs in the accreditation process. So there are 5 of these ROPs related to creating a safety culture within the organization. There are 6 of these related to communication and the problems that lack of communication can create within an organization. There are 6 related to medication use. There are 5 related to work life or workforce. There are 5 related to infection control, and there are 6 related to risk assessment. If you do not perform these required organization practices, you cannot be accredited. So it has taken several years to actually build these in and to see progress in meeting the practices. As a conclusion to this lesson, I would say as much as we have done already, we're still not doing enough. We still have major safety problems. So our vigilance and our developmental processes cannot stop in this area. Lesson 3 is a more recent lesson for us. We have found that you can't have quality healthcare without quality leaders. And I give to you a quote to start this discussion from two people called Graham Dixon and Hugh MacLeod. Graham Dixon is a major researcher in Canada, and Hugh MacLeod was up until a week or so ago, was the head of the Canadian Patient Safety Institute. What happened in Canada is we began about 2004 to realize that if we didn't make some strides in creating the right kind of leaders for our country, that we would not be able to sustain our system. And so many organizations, now today 38 in number, national organizations, associations, and governments, many of our provincial governments and our representatives of our federal government, came together in a unified effort to make a dent in the development of leaders. Accreditation Canada is a member and partner in this, what is now called the Canadian Health Leadership Network, or CHLNet, as it is fondly known. It was officially created in 2009. What the network has been involved with is creating a framework for leadership. It's called the LEADS framework. And I don't know from your angle if you can see the red, but the little red dots, the elements of the framework are, first of all, that leaders have to lead themselves, which means that they have to develop and ensure that their skills are good. They have to be able to engage others, the E, L-E. They have to achieve results. They have to develop coalitions. And they have to be dedicated to systems transformation. In Canada, this is a huge issue at the moment because all of our systems are changing. So the LEADS framework was developed, and tools have been developed to help to measure these leadership elements. Accreditation Canada, as a partner in this effort, began to put more emphasis on 4 standards. And one of those 4 standards, or areas of standards, was leadership and is leadership. So the 4 are governance, leadership, infection prevention and control, and medication management. So while we've made certain strides, I would tell you that we need to go a lot further in leadership for quality. We need to see leadership not as the top of our organizations, but as threaded throughout our organizations. And we're currently trying to present that message. Lesson 4, and this should be no surprise to anyone, there is a cost to quality. Now, I think there would be also general acknowledgement that there is a cost of no quality. And that would certainly be greater. But there is a cost for monitoring, evaluating, and improving quality. And accreditation as a quality monitoring tool is seen by its requirements to create costs in healthcare organizations. As much as we would argue that organizations should be engaged in these activities anyway, it is seen to be attributable to the requirements of accreditation. So there is a constant tension between the cost of accreditation and the value of accreditation. And there's consequently a constant need to demonstrate that value is greater than cost. And that is a constant challenge. And like many areas of quality, we still need more research to help support the fact that there is value in monitoring quality. Lesson 5, and again, perhaps this will come as no surprise to you, quality never has a firm place on the political agenda or agendas. Frequently, quality is overshadowed by more targeted issues, such as the need to cut budgets, the compelling demands for funding for other things than health, such as education or the development of infrastructure. In Canada, we have a two-tier way of funding healthcare, where our federal government provides money through taxes to each of our 10 provinces, but our provinces also have the possibility of taxing. And a lot of the taxes now, almost up to 40 or 50% in most provinces, must be spent on healthcare. So what has happened as a result of this funding situation is that we've had multiple iterations of health system reforms. So our country often describes itself as in a state of change fatigue. We change every few years how we're organized, and people are very tired of that. So what happens is that this has an impact on quality. There is more attention to change, but less attention to the change for better quality. We have this enormous impact as well of regionalization, and what I can tell you here is we have again, each province doing its own kind of development or in regionalization. But in one of our provinces, to give you an example, the province of Alberta, which is our oil-producing province, or our primary oil-producing province, that province has now created one region. There are no longer separate organizations. There is one CEO for this region. This region is 4 million plus population and over 662 square kilometers, or in miles, 256 square miles. So one CEO manages everything to do with healthcare: acute care, long-term care, mental health, rehab, home care, social service, etc. So you can imagine what it's like to try to accredit this organization. That has required ingenuity. It has required different kinds of approaches to accreditation. So Accreditation Canada has had to adjust survey methods to the regionalized organizations, had to adjust to changing government priorities. There's a constant advocacy by Accreditation Canada for quality and quality monitoring, but oftentimes that constant advocacy has to compete with many other conflicting interests. We also have and I'm sure this is true here too, there are frequently changing priorities, changing issues. So one day we concentrate on waiting lists, because we have bad waiting lists. The next day we would concentrate on long-term care, because there have been priority things happening in long-term care. Or we will concentrate on health manpower and the shortage of it. So those changing targets are always there. So what it means is that you never have a firm place for quality on the political agenda. It's always changing. Lesson 6, and I'm now turning away from Accreditation Canada to a couple of observations from my international work, and I've worked in probably over 25 or 30 different countries now. Quality cannot become just a bandwagon, as we would say, or a catchy mantra. Many countries want to build better healthcare systems. They want to redesign their systems, and their stated goal is to improve quality. But actually, what they want to do is control costs, or they want to reorganize the system, or they want to equalize services across the population, or they want to follow international trends, often to gain status. Not that those don't have something to do with quality, but the real emphasis on quality and quality monitoring frequently gets lost. Lesson 7 is related to lesson 6, and that is that the focus of international funding for quality has sometimes questionable results. Now, we're very fortunate that we have the WHO, we have the World Bank, we have the European Union, we have USAID, and many other funders, and they support the development of quality systems. But what happens is often this funding is actually pretty poorly managed at the local level. The expected results related to quality are often not clear, and the evaluation of results from the projects are not done. The other thing that happens is that knowledge transfer, which is often at the heart of this funding, doesn't occur. Or it can be very superficial in its nature. So whatever efforts are made toward quality and quality improvement are not sustainable when the funding is terminated. So you might have, as has already been mentioned, a change of government priorities. You can have a lack of ongoing funding to support what has been put in place. You can have a lack of sustained interest, or probably most important, you don't have buy-in from the local providers to sustain what has been done. So the lesson here is that we really need to be much more careful about looking at how our international funding influences, but also what it produces when it is given on large scales. I now turn to ISQua for a minute. You've already heard we're celebrating the 30th anniversary of ISQua, and there are some lessons to be learned from ISQua as well. The first lesson, quality of healthcare is an international concern which can be shared. ISQua is a forum for international sharing of quality related to research, best practice, dialogue and learning, cooperative and collaborative undertakings, exploration of new and innovative solutions. We need to continue to develop and define an international language of quality which we can all speak and understand, and we must be able to continue to talk to one another to share our learnings. Lesson 9, again, from the vantage point of ISQua, there is a desire for international standards for healthcare quality. ISQua, through its international cooperative effort, has developed internationally accepted and recognized programs for accreditation of healthcare and social care standards. And you can see here that standards from 115 different organizations have been accredited. Accreditation of external evaluation programs, and these are accreditation agencies or evaluation agencies, so 58 of those have thus far been accredited. And accreditation of surveyor training programs, and there have been 22 of those that have been accredited thus far. And just to show you how the program is growing, in 2015, there will be 40 or more surveys done in 1 year. So each year, the interest in international standards grows and continues to develop. The challenges for ISQua, there is a constant development to ensure that the focus of the standards is on best practice. So the standards are constantly being revised with the help of the international community so that we can assure that, they are applicable in whatever country they are used, and that they, in fact, continue to focus on best practice. There is always, as programs expand, there is a need to protect the integrity of the program as it grows, so that it doesn't get diluted by the more countries that use it or the wider applicability of it. My final lesson, again with ISQua. What began in Udine, here in Udine 30 years ago, has had positive results. A few visionaries, and many of them are here in this room, provided the impetus for development of an international agenda for quality. This required dedication, hard work, and a belief in what was possible. Small gains were made over time, and these led to increasing influence in spite of very limited resources. Trends in quality were identified, pursued, and promoted. And here, just to give you some idea, we started, many of us, we could even start with quality control. We went through quality assurance. We are in an era of quality improvement. We have talked about indicator measurement. We have talked about quality evaluation and accreditation. We've talked about patient safety, patient-centered care, and now increasingly there is an emphasis on leadership for quality. So today, ISQua is a leading and recognized international organization for quality. Tomorrow, we need even greater international influence for quality, but we need the visionaries that we had in the past for the future. So we hope that many of you will become visionaries for the future, and that you will have steadfast dedication and continue to be there. And especially, we hope that it will lead ISQua on. So with that, those are my 10 lessons, and I thank you very much.